have many young people, males, who had in the past deep vein thrombosis, were seen by medical people who never thought about Behçet disease. I think if I'm in the field of medicine, any young man coming to me with deep vein thrombosis, I should rule out Behçet. So these patients, they had deep vein thrombosis before they developed Behçet disease. And CNS symptoms, not very common, but we have recently a 14-year-old patient with Behçet disease came to the emergency room on Friday evening with third nerve palsy. Any of the residents here saw the patient? And then he was referred to neurology. 2 days later, I saw him on Monday clinic. He had hemiparesis. So Behçet of the central nervous system can be seen. So if you look at how would you diagnose Behçet disease, there is no diagnostic lab test. So it's a clinical diagnosis based on criteria proposed by international study group of Behçet disease. The criteria require, as I said, recurrent oral ulceration as an essential symptom, plus any 2 or more symptoms of genital ulceration, eye lesions, skin lesions, and a positive pathology test to make diagnosis of Behçet disease. So it's a clinical diagnosis based on this clinical criteria. No lab test. As I said, ocular inflammation, this is based on Japanese data, developed in about 70% of patients in Japan, and this percentage is lower in other countries. Usually, eye manifestation develop later than oral ulceration. That's why we always should have oral ulceration. It is bilateral, non-granulomatous, recurrent and explosive. I like this term, explosive. It's explosive synovitis. When you see the patients, severe anterior segment inflammation, severe vitritis, severe optic nerve head inflammation, severe cystoid macular edema, severe vasculitis and vascular leakage. It's like there is انفجار في داخل العين. And it is bilateral, but rarely we see unilateral cases. Hypopion is seen in about 1/3 of the cases, and here the cells move easily to differentiate it from HLB27 uveitis. As I said, retinal vasculitis and recurrent vaso-occlusive retinal vasculitis are the major cause of visual morbidity. That tends to cause retinal atrophy if you don't control the inflammation properly. Because the more the episodes of recurrent inflammation, the more, and we see this, unfortunately, up till now, we see many patients, even treated in good hospitals, and they come with disease with retinal atrophy and optic nerve head atrophy. Retinal or chalky white retinitis, retinal infiltrates, and chalky white retinitis are very important signs because it can be the first sign of a flare-up. Cystoid macular edema is common, and what is peculiar with Behçet disease is inflammatory retinal vein occlusion. Central or branch retinal vein occlusion is characteristic for Behçet disease, and if you see inflammatory retinal vein occlusion, you should think always about Behçet disease. Fluorescein angiography is very diagnostic. You see diffuse leakage from the optic nerve, from the macula, because of cystoid macular edema, but not the major retinal vessels, but also each capillary is leaking. And this is diagnostic for VKH, for Behçet disease. I'm going to show you examples. This is hypopion. Now, this is fluid hypopion. If you aspirate this hypopion, it will be full of neutrophils. Then, this is the right eye. The patient had retinitis in the macula and patches of retinitis mixed with intraretinal hemorrhages elsewhere. This retinitis is typical for Behçet disease. Some people who might not have enough experience with Behçet, they might misdiagnose this for viral. I'm going to tell the same story that I said, perhaps told several times. In one of the Moorfield uveitis courses in London, a group from Moorfield were present. There was a session on, this course is done for European ophthalmologists. So a group from London, from Moorfield Hospital, were showing, we have a session to present challenging cases. So they were showing challenging cases, and one of the cases, they were showing picture like this, and he said, oh, we suspected viral retinitis. We gave the patient antiviral therapy. And then the disease recurred again. So I told them, this is a classic case of patient retinitis. They kept quiet, but later on, the rest of the story, the Dr. Marwan, our colleague, he was visiting Moorfield for 2 weeks. That was some years ago. And he told me after I came back, said, okay, I saw with them a patient, said, it was Dr. Al-Wasar who made the diagnosis. If you are familiar with the disease, so you should not miss these patches of retinitis in patients. And this retinitis be the first sign of a relapse. So you have to look for it carefully. We frequently diagnose flare-up just by seeing one or two of these patches of retinitis, and it can develop anywhere. It can be associated with intraretinal hemorrhages, as you see here, and on fluorescein angiography, they are silent. It's not like toxo. Toxo retinitis will show hypofluorescence early and then late staining. But the patient retinitis are silent on fluorescein angiography. Now look at fluorescein. Look at this. Each capillary is leaking, and this is pathognomonic for Behçet disease. Another case, these retinitis patches can be many and can be even large. This is another page. I'm showing you many examples so you will not miss it in the emergency room. And look at this, many patches of retinitis with intraretinal hemorrhages, and look at the diffuse capillary leakage. Another case of retinitis, you see the capillary leakage. Retinitis can be here in the macula, close to the optic nerve, and you see the leakage from the optic nerve. Vasculitis, vascular sheathing. And then you can see a patient with severe vitritis. Vitritis is very common in these patients, but through it you can see the retinitis. So this is a patient, this is a presentation, but look here. What do you see here? And here, vascular sheathing, and here vascular sheathing. But look here along the infratemporal vascular arcade. You see there is venous congestion and tortuosity, right? With intraretinal hemorrhage, suggesting what? Inflammatory. Why did I call it? I was in Venice last June, was called summer course for European ophthalmologists. And then some of the audience were confused. Why do you call it inflammatory vein occlusion? Why? It's very simple. Because we have sheathing. If you see sheathing with the vein occlusion, then it's called inflammatory vein occlusion. There's inflammation. Is that clear? And then you see this is the involved vein and peripheral ischemia. Now this is another patient with inflammatory vein occlusion. You see the sheathing. And then you see deep hemorrhages. And this is common in Behçet with this hemorrhages, deep hemorrhages, are the result of what's called hemorrhagic infarction. And then look here to confirm we have branch vein occlusion. Look at the filling of the infratemporal vein. The infratemporal vein is not filled, while the supratemporal vein is filled already. Clear? This is another patient with inflammatory vein occlusion. Why did I say inflammatory? Because of the sheathing. But here, what is this? Collaterals, which confirms that the patient had vein occlusion. So, when you see inflammatory vein occlusion, always think about Behçet disease. This is another patient, but this is very interesting case. The patient had what looked like central retinal vein occlusion. But look here. You see sheathing. This fundus picture is very stormy. But after infliximab, I'm seeing a patient had 20/20 vision. We'll show you the outcome of the treatment later on. And then cystoid macular edema is common. And what is this? This is end-stage Behçet disease. Patient was treated only with corticosteroid monotherapy, in a big hospital, and he ended with this: atrophy, retinal atrophy, optic nerve head atrophy, and the sclerosed vessels, only counting finger vision. Alhamdulillah, we don't see this picture anymore. And I shall tell you why. Treatment. So I'm going to spend some time in the treatment. Everyone in this room should know that Behçet disease remains active for 1 or 2 decades of the patient's life. Then after that, there is self-control of the disease. So our goal in the management of Behçet disease is to reduce the number of flare-ups and to make every flare-up as short as possible to preserve retinal function so that the patient, after he passes this activity phase, can continue to see. So main goals in the management are rapid resolution of intraocular inflammation. I'll tell you how could we achieve rapid resolution of intraocular inflammation, prevention of recurrent attacks, achievement of complete remission, and preservation of vision. Alhamdulillah, now we achieve these goals, at least in our clinic, with the medications that we have. In the past, if you look at the old literature, it was said that despite intensive therapeutic attempts using conventional treatment, I mean by conventional immunosuppressive therapy, steroid and other immunomodulating agents, 15 to 50% of the patients were blind. The first grand round, one of the first grand rounds that I attended here, when I came to Riyadh, the speaker, he was talking about Behçet disease, and he has main conclusion that the patients become blind irrespective of what you do for them. This is not correct anymore. If you look at the treatment, corticosteroids in managing patients with uveitis have only one advantage, that they act very fast. They act very fast. But in long term, steroids are not able to control and prevent blindness due to Behçet disease. That's why I added this statement here: systemic corticosteroid monotherapy must be avoided. Patients with Behçet uveitis will never respond to, on long term, to corticosteroid monotherapy. But if a patient presenting with explosive uveitis, then using steroids as a start of treatment, in addition to another drug like Cellcept, mycophenolate mofetil, cyclosporin, because these drugs take time to act, at least 8 weeks. So steroids, they act very fast, so you need to control the inflammation with the steroids, taper the steroids to reduce the risk of complications of steroids. And as I always say, corticosteroids are the most toxic drugs that you can treat a patient with. And then you continue the control with immunomodulatory agents such as mycophenolate mofetil, cyclosporin. We don't use anymore as a thiopurine or Imuran because mycophenolate mofetil is more effective and less complications. Tacrolimus also is another choice. As I said, systemic corticosteroids alone often fail to prevent recurrences and thus are frequently used in combination with other immunomodulatory drugs. The other drugs that you can use in the patients to maintain the control is cyclosporin A. It blocks the synthesis of interleukin 2 and therefore is a potent T cell proliferating agent. So the cyclosporin and tacrolimus are considered to be T cell inhibitors. So it is combined with prednisone, allowing use of lower doses. The starting dose is 2 to 5 milligram per kg body weight. We always start 5 milligram per kg body weight, given in 2 doses. And we have to know that the side effects are many, and these patients, they need good follow-up with the medical group that we have in our hospitals, that the patients, they are seen by the medical group every 8 weeks, because it can cause renal impairment, neurologic abnormalities, hypertension, hyperlipidemia, increase the body hair. I have seen some patients, they complain that one of the patients from Al-Qasim once told me that, look, I'm going to marry and I'm becoming like a monkey with a lot of body hair because of cyclosporin. Then we had to stop it for him and to replace it with another drug. Gastrointestinal disturbance, higher incidence of neurobedsheet disease, and gingival hypertrophy. This is another common complaint. Nowadays, we don't use cyclosporin as much as before. Tacrolimus, which is also has a similar mode of action as cyclosporin, and the side effects are the same. Imuran is an antimetabolite. As I said, we stopped using Imuran in our hospital for many years because we prefer mycophenolate mofetil. Colchicine. Colchicine has, in our experience, only one indication. Colchicine is the most effective drug to control oral ulcers and genital ulcers. I still remember a patient many years ago who he suffered a lot of recurrent genital ulcers. He was seen by many people. Then when we started him on colchicine, within 2 days, when I saw him on Thursday, he was extremely happy that for the first time the genital ulcers were controlled. So colchicine is very effective drug to treat recurrent oral and genital ulcers. How does colchicine act? It inhibits neutrophil migration. So as I said, in patients with Behçet, they have hyperfunction of neutrophils, increase the chemotaxis of neutrophils into the eye. And this is, we showed this in our recent publication, that the neutrophil chemoattractants are strongly upregulated in patient with Behçet disease. If you compare patient Behçet disease and HLB27 associated uveitis, the levels were much higher than VKH and sarcoidosis. And we know also that in HLB27 associated uveitis, neutrophils are involved. But we know that colchicine is not effective for uveitis. It is only for mucocutaneous disease. Side effects of colchicine: gastrointestinal upset, bone marrow suppression. So if I have a patient that eye is under control, but frequently, if the eye is controlled, the mouth ulcers and genital ulcers are also controlled. Now, years ago, our friend and colleague in Germany, Manfred Roth, he started propagating interferon alpha 2A. You know, in Germany, there are a lot of Turkish people living in Germany. That's why our German colleagues in the field of uveitis, they have good experience with Behçet disease. So they started using interferon alpha 2A as a biologic with a lot of success. And they started first with patients who are resistant to conventional immunosuppressive agents. And they found that, according to their publications, it's effective and safe for the long-term management of severe uveitis associated with Behçet disease in the majority of patients studied. Some patients, they could have long-term remission after you stop interferon. But doses are different according to the experience of our colleagues. In Germany, they prefer to start a very high dose, 60 million units subcutaneous daily, very high dose. But this high dose will induce severe flu-like illness. And Manfred always telling that the fact that the patient developed flu-like illness is a good sign for him that the drug is working. Our colleagues in other in other countries, they use only 3 million units 3 times a week. And they claim that it is as effective as 60 million units. So the side effects are many. Flu-like symptoms, this is the most disturbing complication to the patient. Mild alopecia, leukopenia, development of autoantibodies, Hashimoto's thyroiditis, so it can induce autoimmune disease, psoriasis, depression, worsening of epileptic attacks. But fortunately, all these complications are reversible with a reduction in dosage. In our hospital, we are trying to get interferon alpha 2A, but there are some difficulties because it is not available in the country. Now, if you look at the centers dealing with special disease, colleagues in Germany, they prefer interferon alpha 2A as a biologic. We here, and also the Japanese, we prefer anti-TNF alpha agents. And here we have more experience with anti-tumor necrosis factor alpha agents, particularly infliximab and adalimumab. Infliximab is a mouse human chimeric immunoglobulin G1 monoclonal antibody that blocks the soluble as well as the transmembrane tumor necrosis factor alpha. You know, tumor necrosis factor alpha is mainly present as a transmembrane, and it is released in response to a protease. It's called ADAM17. So ADAM17 will cause the release to make it as a soluble. And so infliximab will block both the transmembrane and the soluble tumor necrosis factor alpha. And as I said, from our studies, we showed that tumor necrosis factor alpha levels as a pro-inflammatory cytokines are strongly upregulated in patient disease compared to other uveitic entities. Why it is called the chimeric? Because part of the molecule is of mouse origin. That's why some of the patients can become allergic and develop a severe anaphylactic reaction during the infusion. It's given as intravenous infusion, 5 milligram per kg over 2 hours at weeks. We start at week 0, 2, 6, and then every 8 weeks. This is how we started. We were following the protocol proposed by rheumatologists. But now we know that many patients, if you give it every 8 weeks, they tend to have flare-up few days before the 8-week scheduled infusion. So we give it at the beginning every 6 weeks. The most serious side effect is tuberculosis. Infliximab can induce tuberculosis. That's why before we start infliximab infusions, we check the patient for BBD skin test very carefully. And if the patient is positive, we should give prophylactic treatment with INH. Alhamdulillah, so far, we did not, although we are using infliximab in many patients, we did not encounter this complication because the patients are seen by us, by the medical, and it should be cleared also by medical. Reactions can happen, reactivation of tuberculosis, and any infections, and you can induce with infliximab. In our study, we showed that most of the patients, after receiving repeated infusions, they develop autoantibodies, anti-nuclear antibody and anti-double-stranded DNA antibodies, but without manifestations of systemic lupus erythematosus. There is also fear of alienating disease. So this is just a table to show you a summary of the studies that looked at the efficacy of infliximab. And you can see here the side effects, complication, tuberculosis, thoracic herpes zoster, and pulmonary TB in this study, infusion reactions. So this is the pattern of complications that you would expect to see in patient. Infusion reaction, in fact, is common. So the conclusions of all these studies, including our study, is that infliximab is safe and efficient for long-term management of refractory uveitis associated with Behçet disease. It does not control only eye inflammation, but it controls also mouth ulcers, genital ulcers. The patient needs repeated infusions. Our experience told us the patient needs, if you stop it, it will flare up. But what happened, what we see in our patients, that we give every 6 weeks, the patient is quiet. We try to prolong the interval. We'll make it 8 weeks, and then 10 weeks. And in our study, we showed that in about 25% of the patients, after receiving many infusions and the eye is quiet, we could stop infliximab, and many of these patients remained quiet without infliximab. This can be due to either that, as I said, the disease remained active for 1 or 2 decades of the patient life, that the patient already had burned out Behçet disease, or, as it has been shown in rheumatology, if you start infliximab early in the course of the disease in patients with rheumatoid arthritis and inflammatory bowel disease, if you start it early during the therapeutic window of opportunity, then you can manipulate the immune system and you can cure the disease. What is the observation that those who are using infliximab made is that the infliximab acts very fast. Very fast. Next day, the patient starts seeing again. And this is our study that it was a thesis of Dr. Sultan al-Rashidi on long-term clinical outcomes in patients with refractory uveitis associated with Behçet disease, treated with infliximab. Hello? Hello? I am in a lecture. Can you call me after 30 minutes? Okay. So, and in fact, when we published this paper, that was the largest, the paper that had the large number of patients from one center. So our study confirmed previous studies that showed the efficacy of infliximab therapy for treating refractory uveitis Behçet disease, and our results confirmed the impressive rapid effect of infliximab in suppressing acute ocular inflammation in patients with Behçet disease. I'm going to show you examples of patients from our clinic. So this patient, as you can see here, what's this? Retinitis, diffuse leakage from the optic nerve, all the capillaries, and this is after infliximab. I'm going to mention at the end of this lecture that nowadays infliximab anti-TNF alpha agents should be given as a first-line treatment in a patient like this. In the past, when we started with biologics like infliximab, we were giving it if the patient failed conventional treatment. This is not accepted anymore these days. If a patient presents with posterior segment inflammation, then infliximab or adalimumab should be used as first-line treatment. Again, another patient, look at these patches of retinitis, and then after infliximab. Fluorescein angiography before and after infliximab. Infliximab also, we published this, has another advantage that you can, if the patient has cataract, you can do the cataract while the patient using infliximab without any recurrence of inflammation. This is before and after. But again, infliximab is very effective to control macular edema. Macular edema is very common in patients with Behçet disease, and it's a blinding disease. So infliximab can control macular edema. Look at this patient, very severe vitritis, optic nerve inflammation, diffuse leakage, and after infliximab, so the vision is 20/20. Most of our patients, if they present to us for the first time or the first episode of inflammation before destruction of the retina, they achieve 20/20, like this patient. And look at the OCT. It induces also rapid control of cystoid macular edema. This is the patient I told you. The patient had inflammatory central retinal vein occlusion. Why? Because there is vascular sheathing. And the patient, after infliximab, he achieved the 20/20 vision. Another patient with inflammatory branch vein occlusion after infliximab. Look at this patient. This is a true explosive banuveitis and after infliximab. This is a patient, this is a type of retinitis that can be confused as viral, right? But this is patient. This retinitis patch can be large. That was a young male, and as you see, severe vitritis, large patches of retinitis. But the fluorescein will help you also when you see leakage involving the capillaries. And he is having 20/20 vision, and now he's receiving infliximab, I think, once every 3 months. Now, adalimumab, this is anti-tumor necrosis factor alpha agent, and it is given subcutaneously. It's completely humanized. We use adalimumab mainly for those patients who become allergic to infliximab, because in our experience, infliximab is more effective than adalimumab. So it is humanized. It is given subcutaneously every other week. You can start with a loading dose of 80 milligram, and then you give in adults 40 milligram every other week, in the children 20 milligram every other week. And there are many studies that showed efficacy. Now, tocilizumab, this is a new biologic for Behçet disease. Tocilizumab is a biologic that blocks interleukin-6 receptor. Interleukin-6 is a multipotent pro-inflammatory cytokine regulating both B cells and T cell activation differentiation. We looked also at interleukin-6 or IL-6 in the aqueous humor. What did we see? Interleukin-6 controls in patients with uveitis, very high levels in uveitis. Then we split the patient according to the disease and look at the levels in HLB27 and the Behçet. So it has the same direction as TNF-alpha. It is mostly upregulated, but look here at VKH, very low levels, sarcoidosis, very low levels. So it's meaning that if you want to block IL-6 by tocilizumab, so tocilizumab would be most effective in patients with Behçet disease and HLB27, but not in VKH, not in sarcoidosis. And so when we compared non-granulomatous with granulomatous, so it means that tocilizumab should be effective in non-granulomatous uveitis. So meaning that interleukin-6 receptor axis might be a target pathway for the treatment of HLB27 associated uveitis and Behçet disease. In fact, there are only 2 studies in the literature that showed indeed it is correct that tocilizumab given to patients with resistant Behçet uveitis was effective. We have also in our clinic tocilizumab, which we save it because it has been shown that tocilizumab also is very effective in those patients who have resistant macular edema. Now, how about another pro-inflammatory cytokine is interleukin-1. Interleukin-1 beta. It is a potent pro-inflammatory cytokine, and there was a company in the States called Zuma. They were producing a monoclonal antibody, a biologic that blocks IL-1 beta. When they approached us to participate in their study, multicenter study, we told them we apologized. We are not interested to participate in their study because based on our analysis, interleukin-1 beta is not detected in the eye of patient with Behçet, in the aqueous humor, or detected at very low levels. Okay, they continued with their study. So their drug was called gevakizumab, which is a humanized anti-interleukin-1 beta monoclonal antibody. Look at the result. The drug fails phase 3 trials. So it means that analysis of the aqueous humor to look for the molecules that are like cytokines, like chemokines, their receptors will help you to select the biologics. So I think time will, but here I shall finish the lecture by saying that this is based on expert panel recommendation for the use of anti-tumor necrosis factor biologic agents in patients with ocular inflammatory disorders. The recommendation nowadays is that infliximab and adalimumab as anti-TNF-alpha agents should be used as a first-line treatment for patients with ocular manifestation of disease, particularly if the retina is involved. You should not spare it as a second-line treatment if the patient is not responding to conventional treatment. No, you should use it, as this is our policy in our clinic, that patients with partial uveitis presenting with retinitis, macular edema, vasculitis, optic nerve inflammation, we start them immediately on infliximab. Thank you very much for your attention. Any questions? Thank you, Professor. Asking about we have patients refer to us what we call end-stage Behçet disease. This patient, why does he develop macular hole? Because of chronic cystoid macular edema that was never controlled. Most of these patients, they have not only macular hole, but they have also atrophy of the macula. I don't think that surgery to close the hole would be effective in improving vision because there is severe retinal atrophy. Any other question? Okay. Yes.
Thank you very much for this lecture. For how long should we keep the patient on steroid and it's aggressive therapy? Even if the patient is quiet and even is aging.
Yeah, but uveitis as a whole, you control the inflammation, then you taper the treatment, you observe the patient is quiet, then you taper the patient, like مثلا VKH, and so on. But it depends on the response of the patient to treatment. But patients with Behçet, they need treatment for a long time. Okay, shukran.
I don't want anyone else.
الدكتور الساعة 2 هيبدون مش الآن اتوقع في وقت ولا
الساعة
عدى
2 الآن هلا 2 هلا قدم 3-4 دقائق.
الوقت يا دكتور.
طيب.
Is this one the
This
yes,
one?
Yes. I want this lamp to be open as well.
تسلم دكتور أيوة.
So all no consultants coming? That's very important.
Yeah, it's amazing. Like I think they should be there. There's nobody's
يا دكتور but I think because إنه عدى الوقت يا دكتور تلاقيهم يشربوا شيء هيرجعوا.
طيب wait 5 minutes معناها.
ممكن إيه.
Wait 5 minutes.
Wait, yeah, I mean there's nobody now.
Because I think they go to eat something.
I think so too. Eat. Is it 2 o'clock already?
2 and more than 2.
2 o'clock. Yeah.
So, yeah, it's
I will go out
1:59
and
exactly.
I tell Maria to let them go inside.
Okay.
For you, doctor, 2 minutes. Okay?
I should sit in that chair. It's nice.
these people already know about flu vaccine. I was hoping to have more residents and fellows.
You need doctors.
They're outside actually.
They are eating.
Are they coming or not?
No, they are.
Do you want me to call them? Because we're going to.
It's okay, let them take their time, but eventually they have to come in.
Enjoy them.
Let's see if it's working. Yep.
Sorry, all five. Are you ready to start? think we can start, Dr. Rohan. What do you think? Okay. Assalamu alaikum jami'an. Good afternoon, ladies and gentlemen. Today, our speaker is Dr. Ruhi Khan. I'm sure everybody knows Dr. Ruhi. She's been here since 2013. And Dr. Ruhi, she finished her medical school in Pakistan, Dow Medical College. Then she moved to Canada, where she did her fellowship in the Family Medicine Residency Program in British Columbia University. Then after that, she joined us, as I mentioned, 2013. She has really great experience in community medicine and hospital practice. And her main interest actually preventive medicine and patient safety. Today she will talk about the flu vaccine, debunking the myth, why people they are not interested in that. So hopefully she will, after her lecture, everybody will run to do his flu vaccine, inshallah. Hopefully. Please, Dr. Ruhi.
Thank you, Dr. Zaitouni, and good afternoon, everyone. This topic is very close to me, as you mentioned that primary care, preventive medicine is the bulk in the primary care. Before I start this presentation, I would like to request you something. Everyone here in this audience, can you please raise your hand if you have taken the flu vaccination for this season? Okay, still we have quite a few numbers who are not raising their hands. So I hope that after this presentation is done, and if this question is asked one more time, then we will have most of us raising our hands. So first, I would like to review the objectives of today's presentation. I will discuss what is flu, why do we need a new flu vaccine each year, how it is designed, do we really need a flu vaccine, what is the disease burden of influenza virus, the safety and effectiveness of flu vaccine, what are some benefits and some side effects of flu vaccine, and of course, myths about the vaccine. What is flu? Flu is a respiratory viral infection due to influenza virus. There are basically two types of influenza virus, influenza type A and B. Type A has further subtypes, and the subtypes of new strains and the main influenza virus, they circulate each year in flu season. They're mainly spread by droplets and contacts. Incubation period is 5 to 7 days. As we all know, the flu symptoms are fever, cough, sore throat, myalgias. Treatment is usually symptomatic, but sometimes antiviral Tamiflu can be used, especially in severe illness or if there's an epidemic. Complications of flu virus include pneumonia, respiratory distress, respiratory failure, and death. Once somebody has a flu infection, the symptoms can usually last from 5 days to 2 weeks, and the most severe illness is between day 3 and day 5, and after that, most of the time, even if we don't take any medications, we begin to recover. Usually we have a new flu vaccine every year. The reason is that flu virus infects both animals and humans, and they're constantly changing. The change is in two ways: antigenic drift, which is the small genetic changes in the flu virus genes, and which continuously happens over time as the virus replicates. On the contrary, antigenic shift is a big genetic change, but it is very rare for that to happen. Now, the mutations in both animals and human can cause a change in the virulence and immune response, which leads to the need for the new vaccine every year. Now, the types of the flu vaccine in Northern Hemisphere, where we live, the flu season runs from October to March, while in the Southern Hemisphere, the season starts from April and lasts until September. Internationally, there are the vaccines available contains actually 3 inactivated viral strains, the composition of which is reviewed by WHO every 6 months and to ensure protections against the strains which are circulating in each influenza season. The composition of the vaccine is adjusted for the hemisphere in which the vaccine will be used. Thus, the vaccine which is available in one hemisphere may offer only partial protection against the influenza infection in the another hemisphere. But although in some years the viruses in both northern and southern hemisphere may be identical, but that is not very common thing to happen. Now in Saudi Arabia, we are unique because we receive vaccines from both the hemispheres. The reason is that the Hajj season usually falls before the flu season, and MOH wants to keep people safe and give them protections against the flu infections. That's why they get vaccinated with the flu vaccine from the different hemisphere. Now, how does flu vaccine work? Usually they are available as trivalent or quadrivalent intramuscular injections, which contains the inactivated form of the virus. A nasal spray of live attenuated, which is the weakened form of the virus, is also available in the markets. They causes antibodies to develop in the body about 2 weeks after vaccination. These antibodies provides protection against infection with the viruses which are in the vaccine. The seasonal flu vaccine protects against the influenza viruses that research indicates will be most common during the upcoming season. And it is best to administer flu vaccine at the onset of the flu season. So anyone who is 6 months or older can receive the flu vaccine. Now, sends yearly reminder to all our employees to get the flu vaccine as soon as we get the stock from the MOH, which is usually the start of each season, September and in October. This is a very common question asked: do I need a flu shot? Now, people with flu can spread it to others. Influenza virus are spread mainly by droplets which are made when people with flu cough and sneeze or talk. These droplets can land in the mouth and the nose of the people who are at about 6 feet away, or possibly be inhaled in the lungs as well. Now, less common, a person might get a flu by touching the surface or the objects which are infected by flu virus. And then they touch their own mouth and nose, and that is how they get the flu infection. Most healthy adults may be able to infect others beginning 1 day before the symptoms develop and up to 5 to 7 days after becoming sick. Now, I want to specifically talk about the healthcare workers. Now, we are more prone to infection because we are surrounded by viruses, especially my ophthalmology colleagues, because when they're examining the patients, they are very in the close vicinity to the patients. And also, they can get the infection to the contaminated instruments and fomites during some ophthalmic procedures. Now, it's not only that. We also carry virus with us to our homes, to our loved ones, and they may not be as strong as us, like our children and our elders. Flu vaccine protects us and protects them and protects others. This is just an important side note and a reminder that how all healthcare workers can take simple steps to prevent the flu vaccine, to prevent the flu infection. We can stop the virus from spreading using cough and sneezing techniques or use tissue. We should have to dispose the tissue in the bin as soon as possible. We can kill the viruses by cleaning our hands with hand sanitizer or washing. We should avoid direct contact with others when sick. And finally, we should clean the contaminated instruments and surfaces. Now, I will talk about the disease burden of the flu. I will share some numbers to show why some health ministries all around the world are so keen about preventing flu infection and stress the importance of flu vaccine. This is for the flu season 2017 and 2018. CDC estimates that influenza was associated with more than 49 million illnesses, more than 960,000 hospitalizations, more than 79,000 deaths, and more than 22.7 million medical visits in USA. Now, I tried to get the cumulative data for Saudi Arabia, but I could not get it. But this is the slide I got. It is showing the lab-confirmed influenza cases, and I got it from the surveillance site from the KSA. Now, here, the numbers on the y-axis are not very clear, but I can tell you that 75 is the maximum number, which is that bar is touching the number. The x-axis is showing the number of weeks. So the data starts somewhere in October and ending in February. And it's weekly data. The different colors are representing the viruses which were confirmed in the lab and which were the reason for causing either the illness, hospitalizations, or death of the patients who were infected with this virus. Now, in this picture, This is from 2018. The flu rate ranges from 11%. The countries are usually in yellow to more than 30%. The countries are in green. The colors are not very distinct, but you can guess. Now, the circle indicates flu subtypes in each region, while influenza A, which is shown in green to blue, it's predominant in North America. Influenza B, which is shown in red, is more common in Europe. In Middle Eastern and North African regions, both influenza A and B were equally prevalent. Now, around the world every year, worldwide seasonal epidemics causes an estimated 1 billion cases of flu, 250 to 500,000 deaths, and 3 to 5 million cases of severe influenza. One more common question to ask is flu vaccine effective? Now, how well the flu vaccine works or its ability to prevent flu cases can vary from season to season. The flu effectiveness can also vary depending on who is being vaccinated, and at least there are two major factors that play a role in determining the likelihood that flu vaccine will kill virus and will protect a person from the illness. Number one is the immune status of the person being immunized, like the age of the person, the health status. And number two is the similarity or match between the circulating flu virus and the flu vaccine. Now, during years when the flu vaccine is not well matched to the circulating influenza virus in the community, it is possible that little or no benefit from the flu vaccine may be observed. But during the years when there is a good match between the flu vaccine and the circulating virus, it is possible to measure the substantial benefits from flu vaccinations in terms of preventing flu and complications. Now, however, even if the match is good, the benefits of flu vaccination, they may vary, depending on the factors like the characteristics of the person being vaccinated, like what influenza virus are circulating that season, and what type of flu vaccine is used. CDC usually uses mathematical modeling to estimate the burden of illness associated with influenza in terms of cases, hospitalizations, and death. These figures are then used to assess the burden of illness averted by the flu vaccine. That means that how many cases of hospitalizations due to flu virus and deaths are prevented in the United States each year as a result of flu vaccination. Now, recent study shows that flu vaccination reduces the risk of flu illness by 40 to 60% among the overall population during the seasons when most circulating flu viruses are well matched to the flu vaccine. A very important question to consider is if the flu vaccine is safe or not. The flu vaccines have a good safety record. Hundreds and millions of people have been safely receiving flu vaccines in the past 50 years. And there has been extensive research supporting the safety of the flu vaccine. Now, before any vaccine comes in the market, it passes through different phases of testing. Extensive testing can place many years. Once testing in people begins, it can take several more years before clinical studies are complete and the vaccine gets its license. During the stages of development, in phase 1, few healthy volunteers are taken to answer the question. The questions are, is vaccine safe? Does vaccine seem to work? Are there any serious side effects? And how is the size of the dose related to the vaccine? In phase 2, several hundred, and in phase 3, hundreds to thousands of volunteers are taken to ensure vaccine safety before it comes in the market. The process does not stop once the vaccine is being approved. FDA and CDC, they closely monitor the vaccine safety after the public begins using the vaccine. The purpose of monitoring is to watch for serious side effects. And if there's a concern, any concerns about the side effect, the recommendation may change if safety monitoring reveals that the side effect is harmful to the public. Now, the benefits of flu vaccine, as we all know, flu vaccine protects against influenza virus. It can reduce the risk of flu-associated hospitalization for children, for young adults, especially hospital workers, and older adults. It helps prevent serious medical events associated with some chronic conditions. Vaccinations help protect women during the pregnancy. Pregnant women can have vaccine at any stage of the pregnancy, and it not only protects them from the flu infection, it also protects their newborn babies in the first few months of their life. And flu vaccine can be life-saving in children. It also has been shown in several studies that flu vaccine reduces the severity of the illness in people who get vaccinated but still get sick. Now, it is important to understand for us as a healthcare worker that flu vaccine reduces the transmission of virus from us to the vulnerable patients, like people with certain chronic health conditions, very young and very old. It also protects healthcare workers from getting the flu from people around them. This is an example of the benefits of the flu vaccine. In US, flu vaccines prevented, that was in year, it's not the latest one, I think it was in 2013. So in US, flu vaccine prevented 6.6 million cases of influenza-associated illnesses. It also prevented 3.2 million influenza-associated visits to the hospital, and also prevented 79,000 flu-related hospitalization. This is another example from UK. In this example, the Public Health England, they collected the data from the school-going children who were vaccinated for flu vaccine, and they found out that there was 94% reduction in the number of visits to the family physicians by the children who received the flu vaccine, 74% reduction in visit to the ER due to flu-like illnesses, and 93% reduction in hospital admission for the children who were diagnosed as having influenza infection. In adults, they did the same thing, and they found out that there was 59% reduction in the visits to family medicines for the adults who received vaccination for that year. This is for my ophthalmology colleague. I found it very interesting, so I thought I will share it with you. This slide illustrates that flu transmission can occur through eyes as well. This is especially true for H7 type of influenza A virus, which has prevalence for ocular transmission. Although this type of influenza A virus is not included in the flu vaccine, I want to emphasize that eyes can be the portal of flu virus entry as well. Now, the adverse effects of flu vaccine is soreness, swelling, redness at the site of the injection, headache, fever, nausea, muscle aches and pains. Now, some studies have found a small association between Guillain-Barré syndrome and flu vaccination. Overall, these studies estimated that the risk of Guillain-Barré syndrome after flu vaccination is as fewer as 1 to 2 cases per 1 million people vaccinated. Other studies have not found any association between Guillain-Barré and flu vaccine. Even though Guillain-Barré following flu illness is rare, please note that Guillain-Barré syndrome is more common after flu viral illness rather than flu vaccine. One of the rare side effects is anaphylaxis reaction, but we all know that it can happen with anything, even certain foods can cause anaphylaxis reaction. Since the making of the flu vaccine, the virus is grown in eggs, there's a concern that people receiving flu vaccine and they have allergies to egg, they can have a problem. So people who have severe egg allergies, they should receive flu vaccine in hospital settings. So if they exhibit any signs and symptoms of allergic reaction, they can be managed accordingly by the healthcare professional. Now, there are very few contraindications to flu vaccinations. Infants who are younger than 6 months old, they cannot receive flu vaccinations. People who have a past history of life-threatening reaction to flu vaccine, or if they have a history of Guillain-Barré syndrome, they should not receive the vaccine. Now, people receiving biologics, or if they are immunocompromised, the live vaccine, which is the nasal mist, is contraindicated in them, but they can take the inactivated form of flu vaccine, and they have to be just cautious and get the vaccine in the hospital setting as well. Now, this is the most important part of the talk, what are the reasons that people decline flu vaccines? We all have enough knowledge about flu virus and flu vaccine, and still we hesitate to take the vaccines, although it is utmost important, especially us as a healthcare worker, and especially you as ophthalmologists who work in close vicinity with the patients and are at more risk of getting the flu infections. Some of the reasons I will discuss that why flu vaccine is not taken here, and number one reason is flu vaccine causes flu. The shot is made from the flu virus, that is true, but the virus is inactivated, especially the vaccines we are using in KKESH. We don't use live vaccine in KKESH, making it impossible for the vaccine to give you the flu infection. In randomized blinded studies where some people get it, when some people got the inactivated flu shot and some people got saltwater injections, the only difference was more redness and soreness at the site of injection for the people who received the flu vaccination. The other symptoms like body aches, fever, cough, runny nose, there was no difference between the flu vaccination and the saltwater vaccination. Now, one of the most common questions I get from my patients is, what about the people who get the flu vaccine and yet they get sick and severely sick with flu symptoms? There could be severe reasons for that, why someone might get a flu shot, and even after that, they get the flu symptom. One of the reasons is some people can get ill from other respiratory viruses besides influenza virus, for example, rhinovirus. These viruses are also circulating in the flu season. They don't cause serious illness, but they cause the symptoms same as influenza virus. So and they don't offer you protections against them if someone is taking the flu vaccine. So flu vaccine only protects against influenza and not other viruses which are circulating in the community. Now, other explanation is that it is possible to be exposed to influenza virus, which causes the flu shortly before getting vaccinated or during the 2 weeks period after which you receive the vaccination. Now, as we know that it takes the body to develop immune protection in those 2 weeks, the exposure may result in person becoming ill with flu before protection from the vaccine takes effect. One of the reasons why some people may experience flu-like symptoms despite getting vaccination is that they have been exposed to the flu virus that is very different to the virus that they received in the vaccine. That is, the match between the virus that is causing the illness is not good with the virus which is present in the vaccine. The final explanation for experiencing flu symptoms after vaccination is that flu vaccine can vary in how well it works. And some people who are vaccinated, they can still get flu because of their different immune response and immune system. Now, going back to the reason why people are refusing vaccine, some people believe that it is better to get flu rather than the vaccine. Now, if someone gets flu, the infection is usually caused by only one strain of the virus. So their chances of getting reinfection is there because there are so many types of influenza viruses are circulating in the community. So the CDC recommends that you should get the flu vaccination even if you have gotten sick with the flu before that. People are not happy taking flu vaccine every year, and there's a question, why should we take flu vaccine every year? CDC recommends that a yearly flu vaccine for everyone 6 months and older, and this is for 2 reasons. Vaccine's composition may be updated from 1 year to another, and patient immune protection from vaccination declines over time. So it is best to get the flu vaccine every year to get the optimal or best protection from the flu virus. Everybody is scared of bad side effects. I have discussed the side effects. For that, I would like to say one thing. All our lives, our decisions are based on risk and benefits, and while saying should have the same approach when we are saying no to the flu vaccine. Many people believe it's a hype and it's not real. And it does not have any role in preventing flu. Now, we are healthcare professionals and we have access to world-class research. We have access to all type of flu data from all over the world. So we can do our own research and can be advocate for our own patients, colleagues, friends, and family. Now, the next reason is kind of funny one. Somebody once told me that they don't want the flu vaccine because they don't want any foreign body in their system. But the thing is that what do we do at dinner every night? Now, the next one, the fear of needles is real. But we have to consider this. If we can give needles to our babies and our children, then at least we should try to overcome this fear. Many people believe that taking vitamin C and eating healthy, they won't get flu. But there's no hard evidence about that. Now, anti-vaxxers. Many people are anti-vaccines. Research has shown that vaccine hysteria is detrimental because it causes increase in morbidity and mortality from preventable diseases. At the same time, it jeopardizes the research for new vaccines. For a healthcare worker to be against vaccine is a tough call because it is against the basic principles of medicine. All of us are very busy at work, and many times we don't have time to come to the EH for our vaccine. But just let me say that MOH is putting a lot of effort and emphasis on the flu vaccine for the reasons which are discussed above. And also, the disease burden of MERS-CoV is also there. So we can play our role by vaccinating ourselves against at least one virus, and this is the small role that we will play so that the disease burden of the viral illness is decreased in this country and around the world. It is also very interesting to note that the impact of the increased flu burden on the healthcare system, it includes cost to MOH. It also results in loss of work days and disruption of workflow for the employers. And at the same time, it also causes pain and functional impairment of an individual as a consequences of the illness. Now, EH is trying its best to reach out. We have booth at the Grand Rounds for the flu vaccine. If you cannot come to us because you're busy, we are willing to come to you. Just give us suggestions. How would you like to take your flu vaccine? We will follow it because we are in it together. This shows in percentage the common reasons for declining the flu vaccine. It includes misconceptions about vaccine risk. Patients believe that sometimes they can never get flu. They are scared of needles. Sometimes they just don't care. Sometimes they are anti-vaxxers and they're opposing all the vaccines. And sometimes they have a valid reason because they have serious allergies to vaccine. However, the most common reasons as per CDC is the misconceptions and myths regarding the flu vaccine. Now this slide recaps the common flu myths. The flu myths are in a darker blue shade and the facts are in the lighter blue. As you can see, the people are concerned that the flu shot can give them the flu. They are concerned that vaccines will not prevent flu and it's a hype. They're also concerned that they should wait to get vaccinated towards the end of the year so that most of the disease burden is less at that time. They are thinking that it is better to get the flu, it's healthier to get the flu than the flu vaccine. These are also very common myths. Well, I don't see many residents and fellows here, I'm sorry about that, but I was thinking that the Hippocratic oath that we take when we finish the medical school, it will be fresh for them. One of the points is first do no harm. And I want to emphasize on it with respect of the flu vaccine. So healthcare workers may transmit the illness to patients even if they are mildly or subclinically infected. The patient we saw, especially our ophthalmology colleague for eye illness after being discharged, may have contracted the flu from us. They may be young, they may be old, there's a chance that they may have become severely ill, hospitalized, or even died. We would never know because many times they don't come back to us. Now, if you don't want to get vaccinations for yourself, do it for others. You may not even know that your colleague may have impaired immunity because of the chronic health condition or any medical reason. You don't want to harm them, and you don't want to harm your patients or your family members for that matter. So taking pain for others is a gesture of kindness, in my opinion. Just to let you know, some of the hospitals in USA, it is mandatory to take flu vaccine as a part of the renewal of the service contract. For me, I don't like to force people to take vaccinations, but informed decision is the best way to go. And that is the reason I'm here talking to you guys about flu vaccination. Towards the end, I will share my KKESH experience with you. Now, the vaccine administered in the flu season, which was the last year, 2017-2018, which started in October and ended in May, was 715. For this flu season, which is still ongoing, the vaccine given to our employees and the dependents from October until February is 423. Now, EH visit for a flu-like illness in 2018 and 2019 from October to February is 376. And out of those, only 53 received the flu vaccine. This is in graph. As you can see, the bulk of the vaccines are taken in the early flu season. And we are already in March, so I don't see any hope of people coming now and getting the flu vaccine. And from last year, we are doing poorly for several reasons, and we really want to keep yourself and people around you safe. The CDC recommends that flu vaccines should continue to be offered to unvaccinated people throughout the flu season as long as vaccine is still available. So it is really never too late to get the flu vaccine. Now, I would like to thank you for your attention, and I am purposely finishing a little early because I want to hear from you guys. The reason I was asked to give this presentation is that we want to increase the rate of flu vaccination, if possible, to 100% for our employees. Now, any ideas, any suggestions, any concerns, all are welcome. Yes.
We had the one in October, and then they said we were told we might have to have it again in December.
Yes, so as I said, that the October vaccine we received was the vaccine which was left over for the pilgrimage, the Hajj people, and it was from Southern Hemisphere. Then again, we got the vaccine for our own hemisphere, which we received, I think, in late in November, we were a little late in receiving those vaccines. And as a matter of fact, there was one new strain in the vaccine which was received later. So people who were vaccinated before, we didn't ask them to come because even coming first time is a problem. But ideally, they should have received the new vaccine as well because it contains the new strain. And that is what CDC says. Even if it's a single new strain, you should revaccinate yourself, no matter when was the last time you received the vaccination.
But nothing was circulated to us about the new strain.
What is that?
Nothing was circulated to us.
Yes, we did not inform our patients because the new vaccines was received kind of quite late. Yes. It was received, I think, in December or something. Any ideas, how can we improve the vaccination rate? The people who didn't raise their hands, they are not vaccinated. Can you share your concerns, why you haven't vaccinated yourself?
Okay, first, I didn't get the vaccine yet because I hear that some people, they get the vaccine, after that they become very sick. This is the first reason. Another point that lately you make like a schedule to visit each department from employee health to give the vaccine. Then you said that the vaccine is not available. We are waiting.
There was a shortage of the vaccine only for a couple of weeks. Then we informed again all the departments that the vaccine is there. And actually after that, we have been trying actively to reach all the departments one by one. Either our nurses are trying to get there, but unfortunately there is a problem with the nursing staff in our department right now. But we're inviting you to come over and get the vaccine.
Okay,
we have informed all the managers already.
We can go back to the schedule and to choose one date for our department to go there and to get the vaccine.
And if you haven't taken the vaccine because you're scared that it will make you sick, wait till you get the real flu. I hope not.
Thank you very much, Dr. Ruhi, for
Thank
excellent lecture, really. And as she said, we are trying really to send nurse to each department for vaccination, and this will start soon again. We got more vaccine now. We didn't get staff, but we are trying to save some staff from pre-hospital help EH to send them for vaccination. But I urge, please, people who were not vaccinated to be vaccinated, and even including their family, they can bring their family for vaccination. Thank you very much.
And I think,
again.
sorry, the resident fellows who are not here, they are the ones who are really not vaccinated, but I don't know, they didn't attend the lecture. Thank you.
Thank you very much again.
ليه؟ انت وش تبغاني اسوي بس؟
لا بنشوف بنشوف.
بتسجلونها؟
بعد كذا خلاص ما تسجل صح؟ تسجل في
إيه لا انا ما ابغاك تسجل.
لا ما تسجل. لكن اللي ترى ذاك اليوم موجودة معي بس انت ما كملت.
اي والله أنا صراحه حسيت انها ثقيله عليك.
So
Abu Zaid.
Alhamdulillah, how are you? والله الحمد لله but still discussion.
Nah,
والله
you are happy there. Good clinic in the future, huh? 2 clinics.
you know me,
You don't.
I don't look for this directly.
Nah. Well, in the future, inshallah, it will be good for you. Good to see you. Good to see you. So I think we can plug your, huh?
It's okay. The HDMI.
No, because I put it on this computer there. So I will unplug my.
you minimize it.
Yeah, it minimize and it's there.
This new turn open, then I will do it for you. No problem for it. جديده.
اي شفتها منشر عليها.
جرب العب.
الله
بيجي
يخليك.
بكسر.
لا معي. الله يعافيك. شكرا. بتستعمل. اوكي. احمد نبدا ناديهم خلاص.
Start or wait?
وين خبر بك
Okay, I think we should start so that we can finish by time, before time maybe. What time we are supposed to finish? 6 o'clock? Oh, we'll try to do a bit sooner than that. So good afternoon everyone. And good afternoon and welcome to the second KKESH. Is it second, isn't it? We did it last year. It's a topography course. And just to get an idea, how many of you are R1? Just raise your hands. R2? Just 1, 2, okay, 3, 4. R3? Good. R4? Good. F1? F2? Anything else? Consultant? I can see one consultant there. And okay. Everybody knows about a pentacam, isn't it? That there is a thing known as pentacam. Everybody knows OBSCAN. And people know that there are topography other than OBSCAN and pentacam. We know that? There are. Everybody knows me? Everybody knows His Excellency Turki bin Dakhil? We are very happy, isn't it? Give him a big clap just for coming here. So the theme is the same as the last year one, and we will start with Turki's talk, which is very extensive, and it starts from the very basic, so it will be helpful for the R1 till F2 and the consultants. So he will talk about the basics of topography, and then he'll talk about pentacam in detail, because this is the one which we use mainly. And then I will touch base OBSCAN, and I'll tell you why I'm just touching it, because we don't use it that frequently, because it is not that sort of effective, okay? And then we'll go back to pentacam, and we'll do some cases, and that will be like interactive, so get ready, so don't sleep, eh? So if I ask Turki to start with his excellent talk.
السلام عليكم. قبل ما ابدا بس ابغى اشكر الار 1 صراحه، لان بفضلهم بعد الله اعطوني هذه الشهاده، فبس بغيت اتشكر منهم قبل ما نبدا. طيب. We will start with topography or tomography. What is topography? What is tomography? What is the difference? Is it all are tomography or all are topography? So the corneal image to start with, it starts with the placido reflection, keratometry, then topography. Then the tomography era started. Start with the scanning slit tomography with topography. So it is tomography and topography. This is Orbiscan. but it is the scanning slit. Then rotating sham plug tomography started. In Bentacam, we have only one rotating sham plug tomography camera, whereas in other tomographer machines, we have two sham plug camera. So, we have one associated with topography. So in Cirrus, Tommy, and Persio, they have Tommy and tomography and topography. But in Bentacam, it is only tomography, so it is not topography. Okay, so that's why we changed the course name from topography to tomography. We have Galili, which is a dual or two rotational sham plug camera with a Placido disc with topography. And also we have OCT tomography, which is Cassini. So if we have a patient, we did for him Bentacam, and next visit we did for him Orbiscan, we cannot compare the results. We should compare Bentacam to Bentacam, Orbiscan to Orbiscan. Okay, the difference between topography and tomography. Topography, it measures the anterior surface of the cornea only, whereas tomography, it gives the a picture about the camera, which is a 3D about the cornea. So, which include measurement of the posterior surface of the cornea. And since we have anterior and posterior surface, we can get the thickness. So the bathymetry, the topography, there's no measurement of the area of thinning, whereas in tomography, we have full bathymetric map with thickness profile. The coverage, topography cover less area than tomography. So in tomography, we can get limbus to limbus or white to white. The error, there is high incidence of false positive in topography due to large angle Kappa, misalignment, and tear disturbance. Whereas in tomography, it is less susceptible to false positive, but also affected by large angle Kappa and misalignment. The corneal scar, when we have corneal scar, Bentacam will not be that good. So you will have thinning, although the cornea is not that thin. So maybe you will have 450 or 400, but actually it is 500 or 470. So in corneal haze or scar, topography is better. And to measure the angle Kappa, also it's better. The AC depth cannot be measured by topography because it's measuring the anterior surface only. Lens analysis also cannot be done, and it is relatively inexpensive. Whereas in tomography, we can measure the AC depth and do lens analysis. Okay, so what are the uses of tomography? We can screen for refractive surgeries, so to detect early and subclinical keratoconus, and detection of early progression in keratoconus, toric IOL planning, post-refractive surgery IOL calculation, diagnosis of peripheral corneal disease like pellucid, corneal wave front, or what's called Zernike analysis, a lens evaluation, and there is a grading system for the Bentacam. Glaucoma assessment, which include assessment of the angle, the AC depth, and the AC volume. Anterior chamber depth also, which is needed in phakic IOL and other indications. So by using full bathymetric map, we can planning for patient with Fuchs if there is thinning or edematous cornea, and we can, or there is a difference between morning and afternoon bathymetric map. And it can provide also corrected IOP measurement. So the patient after refractive surgery or thick cornea, and you measuring the IOP, it is 23, but actually it is 22. And we will come across the corrected values. So, and also you can plan for the depth of intrastromal ring insertion, and the new Bentacam AXL, which include the axial length measurement of the eye. So we can do IOL calculation using the new Bentacam. Okay. أبغى بس volunteer. This is Placido. So if you have these rings, what type of astigmatism? Is it against the rule or with the rule? Against. في أحد طيب يقول إنه with the rule بس عشان نشرح له ليه إنه قالوا against the rule. طيب. So, okay. So this one, it's against the rule, as you said. The horizontal median is the steeper than the vertical, whereas in the one on the left, it is with the rule astigmatism. Okay, so definitions. Form frost. Form frost keratoconus, there is multiple definitions for form frost keratoconus. And in the consensus of keratoconus, there is no clear definition of form frost keratoconus. But usually, when we have one eye with a clinical and tomographic keratoconus, and the other eye still, it is almost normal, but it is not maybe biomechanically normal, we call it form frost. Also, some will call, if we have a patient with keratoconus on Pentacam, but clinically no signs, they will call it form frost. Some will call preoperative tomography of actual post-LASIK ectasia, and the fourth definition is normal tomography with positive family history of keratoconus. But usually when you say form frost, we are following the first definition, usually. But there is no agreement on this one. طيب. Steep versus flat, radius of curvature. في أحد فاهمها ولا؟ The shorter the radius of curvature is the steeper cornea or the lens. So the radius of curvature 6.75 equals to K readings of 50. If the radius of curvature 8.4, the K readings is 40. So when we increase the radius of curvature, we will have flatter. Which one is steeper? 2. So this is 2, it's steeper, okay? So in 1, the K is 40 and 2 is 50. Okay. Corneal axis. Where is the 0 and where is the 180? This is this patient will go for toric IOL implantation at 45 degrees for both eyes. So طيب لا 45 is it 1 or 2 3 or 4 okay اللي يقول 1 and 3 واللي يقول مثلا 1 and 4 1 and 4 واللي 1 3 طيب كويس. So it is 1 and 3. So regardless of laterality, the 0 will clear. X and Y coordinate in the pentacam. Regardless of laterality, this is the x-axis, the plus on that side, and up is the y-axis, the plus. Clear? So now the axis and the coordinates. Okay, angle kappa. What is angle kappa? من اللي بس تفضل. Okay. طيب normal angle kappa positive ولا negative? Positive. أي. But here in pentacam, you will notice that it is in minus and sometimes in plus. Why? Because of this coordinate. Because it's regardless of the coordinate. So let me show you something. So here, on the right eye, it is in minus. This is the pupil location, okay? The center of the pupil. It is in minus in the right eye, and it is in plus in the left eye. Clear? Clear? Why? Because regardless of the laterality, البوزيتيف هناك, النيجاتيف هنا. Clear? But angle kappa is positive, less than 5 degrees. Okay? Angle kappa is important in trifocal IOL, hyperopic ablation, and astigmatism if the correction is more than 1 diopter. Reference surface. The normal corneal shape is a spheric toric ellipsoid. So we have toric ellipsoid on this side and the sphere. When to use best fit sphere, when to use best fit toric ellipsoid. Okay. Best fit toric ellipsoid, it will mask the astigmatism of the cornea. So you will see the high order aberration. What is high order aberration? Usually the sphere cylinder, it is low order aberration. So if you mask it, you will have high order aberration. Okay, coma, trefoil, others. Okay, so toric ellipsoid will take the shape of the cornea, so it will mask the low order aberration. So you will see the corneal irregularities, high order aberration, and it is used in holiday report map. Whereas best fit sphere, it is the best reference surface to screen for refractive surgery and study the shape of the cornea, study the corneal astigmatism, which is low order aberration. So if you want to study the high order aberration, go for toric ellipsoid. And study the corneal elevation and localization of the cone. The best map to localize the cone is best fit sphere on elevation map. Okay. The parameters that affect the reference surface is the chosen radius of curvature and the diameter of study zone. So you can select 8 millimeter diameter or 9 or 7 or 5. And you can choose also the radius of curvature, but usually the machine will give you the radius of curvature. And we have a float mode and non-float mode. The float mode, it is the standard mode. Usually it will take the average of all the keratometric reading. So it will give you the reference surface of these readings. Whereas in non-float mode, it will give you use the corneal apex as the reference. So everything will be just below it. But usually we are not using the non-float mode, but we are using float mode. But if you go for one large map on Pentacam, you can unclick the float mode. But you have to understand why you should check this float mode. Reference surface, it is based on the average keratometric values over a specific corneal diameter. So this is, let's imagine that this is the reference surface of the cornea, the green, and the cornea irregular, which is in blue color. So the irregular cornea can be below or above best fit sphere. Which color will be on Pentacam if it is above best fit sphere? Okay. Blue or red above best fit sphere? It can be either way. Why? Because if you are measuring the curvature map, the one below best fit sphere, it will be red. But elevation map, the one above best fit sphere will be in red. Okay? Clear? اللي ما هي كلير له هذه السلايد يعلمني اوقف، ترى هذه اهم سلايد. بست فيت سفير، طيب خلي اشرح لك اياها بطريقه ثانيه. تخيل انها الاشارات. طيب if it is red means it's dangerous. Okay, so in the curvature you are measuring the K readings. If it is very steep, this is red. And in the elevation, if it is elevated, it is red. So this is the map. It is just like a warning sign for you. So don't depend on the color, just the color, but you have to understand why it is in red, why it is in blue. In keratoconus, you might have, like this, the one below, you might have the cone, and over the cone, although it should be below best fit sphere, it is above best fit sphere because the radius of curvature is higher. So here, this one, it is above, okay, and above also for elevation. But why it is in red, although it is above here? Because it is very steep here. The radius of curvature, if you take only this part, from here to here, it is very steep, steeper than the peripheral part. Clear? The effect of diameter of study zone on best fit sphere and of the elevation map. Okay. So peripheral cornea is flatter. Agree? The central is the steeper. Okay. So if we will take, let's say, if we will take this one, okay, and we will include the peripheral part. Let's say we take 9 millimeter diameter for our best fit sphere. We will include this 41. We will include 42. So we will have best fit sphere 42.5. Whereas if we take this, take only smaller diameter, we'll have best fit sphere 44. So which one do you think it is safer to go? Large? Well, تفضل. يلا. Depends على ايش؟ You will assess all the cornea, but now you will measure the best fit sphere. Okay, best fit sphere. You are measuring the best fit sphere. Do you want a steeper best fit sphere or flatter?
So the question is whether you're going to underestimate or overestimate with a smaller versus bigger. So what will a smaller diameter do? Underestimate or overestimate? You have a diagram? You have a
Yes,
diagram,
yes. طيب. This is 6 millimeter, okay, and this is 8, this is 12. The ideal is 8, but some will go for 9 millimeter. So you will have best fit sphere, let's say on the elevation, it is 17. If you change it to 8, you will have less, okay? It might be 15 or something. So you have to check the diameter of this best fit sphere that you are using. So here in 6 millimeter, the best fit sphere is 50 because you are not including the flat case on the periphery. Okay, clear? But if you include it, the best fit sphere, if you include the peripheral part, the best fit sphere will be depressed. Clear?
The more chance of picking a keratoconus if you're using a 12 one.
Yes.
Missing it if you are using a 6 one. But then you need to find a specificity and sensitivity, and the ideal one is at 8, where you will not miss it and where you will not overestimate it.
Okay. So here in 6 millimeter, the elevation is 20, whereas in 8, 23, and in 12, it is 26.
Which one is correct?
Clear?
The question is what you want to pick from there.
Ideally, we are taking 8. Okay? كل كلامنا بيصير على 8. Clear? طيب. So, if you want to exaggerate everything, take 12. Okay? طيب, colors in Pentacam, and we discussed just 5 minutes ago that it's like a traffic light. Anything in warm color means it is dangerous. But here, as you can see, the warm color, but the warm color will be in red, but the relation of this map to best fit sphere, this is below best fit sphere, whereas this one is above best fit sphere. Spherical aberration. Spherical aberration, you should know this if you will go for trifocal IOLs, if you want to see the Q value of the patient. So let's say the Q value, you will get a Q value from the Pentacam, okay? You can get spherical aberration also. But if you are using holiday report, you will get the spherical aberration. But the Q value, if it is plus, in positive, this is oblate shape of the cornea. If it is in negative Q value, you will have a prolate cornea. The normal cornea is prolate. Okay. The spherical aberration, okay, spherical aberration, to have 0 spherical aberration, okay, of the cornea, you have to have a Q value of minus 0.528 or minus 0.53. So if you if the patient has Q value of minus 0.528, this means zero spherical aberration. But usually, what is the normal Q value, the average Q value? اي بس يعني minus 0.2. طيب اي minus 2.7 2.6 كذا. طيب so الطبيعي والnormal you will have a negative Q value which is a prolate معناها steeper in the center. Okay, the center part of the cornea is steeper than the peripheral. The normal is to have negative Q value with positive spherical aberration. Clear? So the ideal sphericity of the anterior. Okay. So it's minus 0.26. This is the normal or the mean Q value. Okay. Q value. طيب خلصنا الحين spherical aberration. Now the Q value, it represents the corneal asphericity. Asphericity means is it spheric or aspheric? Spheric means the central part of the cornea, the K readings, the keratometric readings, is equal to the periphery. This is sphere. If it is not equal, this is aspherical. Okay. Aspherical can be prolate or oblate. Can be hyperprolate also in keratoconus. So the prolate, you will have central steepening. In oblate, you will have central flattening. Central flattening like post-myopic ablation. Okay. So prolate is negative Q value, spherical is zero Q value, and oblate is positive Q value. Clear? Hyperprolate, it is hyperprolate means negative spherical aberration. After hyperopic ablation, keratoconus, and in mini monovision, we are trying just to get more or negative spherical aberration. And in oblate, after myopic ablation of -3 or above. Depends on the cornea. So which one is hyperprolate, which one is prolate, which one is oblate? We know that the oblate طيب this one hyperprolate. طيب this one oblate because the center is flat. Clear? So spherical aberration, the ocular spherical aberration is the sum of spherical aberration from 4 refracting surfaces of the eye. Anterior corneal surface, posterior corneal surface, and anterior lenticular surface and posterior. Usually, during life, the anterior and posterior corneal surface will be the same, almost the same, but the lenticular surface, the spherical aberration will change. Okay? طيب. In 19-year-old versus 72-year-old, let's say the corneal Q value is minus 0.26, and the spherical aberration of this cornea is plus 0.27, which is positive spherical aberration, and the lenticular spherical aberration is minus 0.27, which is a negative spherical aberration. So 0 spherical aberration. Okay. With age, the lenticular will change. It will become positive. So in elderly, you will have positive spherical aberration. But the Q value, maybe it will be the same. Clear? It will not change, usually. It will not change the Q value with age. This is peripheral rays. When we say this is peripheral rays, and this is central and paraaxial rays. Okay? If in no spherical aberration, both the peripheral and central will be on the fovea, exactly. if the central rays focus in front of, this is peripheral and this is the center, if the central rays focus in front of peripheral rays, this is negative spherical aberration, whereas if the central rays focus behind the peripheral, means it is positive spherical aberration. طيب. اوكي. خلصنا البيسكس. طيب فهمتوها كلها؟ في احد يبغى نرجع؟ اليونغ؟ اي. طيب. ال 19 year old usually في عمر الانسان الوقت اللي ما يصير عندك spherical aberration اذا جاء عمرك 19 غالبا. طيب فالكورنيال it is plus 0.27, the lenticular is minus 0.27. So the spherical aberration is 0. With age, the lens will become more positive. So you will have positive spherical aberration from the cornea and the lens. Clear? طيب. For refractive maps, this is the refractive maps. This is the patient information box, detailed display box, curvature map, which is corneal power map, corneal bathymetry map or corneal thickness, anterior elevation map, posterior elevation map. Detailed display box. Keratometry value box. This is keratometry value box. Okay, we have front surface of the cornea and back surface of the cornea. Quality of specification. The QS is the quality of specification. If it is okay, it will be in white. If it is needs to be repeated, yellow or red. Red means it's not reliable. The patient is not fixating. Okay. Even if it is white, maybe it is not accurate. Here, the patient is fixating toward the right, the temporal. Okay? Although the QS is in white. So you have to be careful. Okay? Clear in fixating to the right. Here. Here, same patient, fixating, has good fixation, and the QS is still white, and everything changed. The keratometric readings, the thickness, everything. The elevation. This is with poor fixation, and this is with good fixation. Okay. Q value, we talked about Q value, and it measures the sphericity. The normal Q value range between minus 0.26 and minus 0.42, although some will consider between 0 and minus 1 is normal. The vertical Q value is the most important, and you have to check here. You have to check here the diameter of this Q value. Okay? If it is 10, we don't need 10. We need 6 millimeter. Okay? So you have to change it to 6 millimeter. Okay. The vertical Q value is more important than the horizontal. Normal Q value, if it is less than 0.5, suspicious if it is between 0.5 and 0.55, and abnormal if it is more than minus 0.55. Okay? So you can get a detailed Q value from the Pentacam. Here's a 6 millimeter, 7, 8, 9, 10, and nasal, temporal, inferior, superior Q value. So here, this one is 10, which equals here. It is the mean Q value, the horizontal and vertical at 10 millimeter. But our concern is here. Okay? This is the horizontal radius of curvature. This is the vertical radius of curvature. This is the flattest horizontal or flattest K reading within the central 3 millimeter of the anterior surface, because this is the front corneal surface. this is the flattest. It is in a blue color. Usually, we should see and check this, the flat K, if we will go for myopic ablation. If the patient is myopic, we should check this K1. If it is below 34 or 35, we should avoid the ablation. Why? طيب. So, and if you want to calculate the post-op flat K after the surgery, you can so you can follow this formula that each 1 diopter of treatment of myopia will cause a flattening of K by 0.8 تقريبا. Okay. This is the steep K within the central 3 millimeter. We should take care about this one in case of also hyperopic treatment, because in hyperopic treatment we are steepening the cornea, so it will become steeper. So if it is, we should not go beyond 48 diopter. So each 1 diopter of treatment of hyperopia will cause a steepening of on the K by 1 or 1.2 diopter. This is the average of K1 and K2. This is the astigmatism of the anterior corneal surface. The manifest astigmatism equals to total corneal astigmatism and lenticular. Okay? Total corneal astigmatism means anterior and minus posterior. Okay? Anterior minus posterior. Why minus? Why not plus? Which surface of the cornea is steeper, the anterior or the posterior? Posterior. Okay. Why minus? It is steeper also. It is steeper. Why it's not more plus? Steeper. Mm-hmm. Excellent. Excellent. طيب هذا للماينس صح؟ عشان كذا ماينس. But why here if we compare the K readings here, okay, although it is steeper the posterior surface, طيب, it will be less than the anterior surface. It is steeper, it should be higher. اي هو refractive index بس كمل الجواب. ايوه. Yes. The difference between two refractive indices. Okay. So the refractive, the difference between air and cornea or tear and the cornea is higher. The difference is higher than the posterior surface and the aqueous. Clear? Total corneal anterior minus posterior corneal surface. Internal astigmatism, it is the topographic minus the manifest. The anterior corneal astigmatism, usually it is with the rule astigmatism, and with age it will become against the rule. The posterior corneal astigmatism, it is with the rule despite the age of the patient. Okay? So anterior corneal surface it will change, but the posterior will not. In the anterior corneal surface astigmatism, compare the absolute value of topographic astigmatism with the manifest astigmatism. Compare also the axis, not only the value. And don't forget that the patient might have astigmatism from the lens, which is lenticular astigmatism. Oblique axis and against the rule astigmatism are worrisome in comparison to with the rule. If the difference between the value or the axis of pentacam is more than 1.5 diopter, or the axis is more than 15 of manifest astigmatism, you should be suspicious. Is there an error in the refraction or the cornea abnormal? Total corneal astigmatism, the anterior and posterior. Usually the posterior, it will be in minus, whereas the anterior, it will be in plus. Okay? If you have like this astigmatism, 1.6 axis 2.8. This is the flat axis, huh? طيب. Flat axis. طيب. And here the astigmatism is in minus with different axes. And you want to go for toric IOL, and you want to know the total corneal astigmatism. The axis is different. How can you add this, the anterior to the posterior? لا subtract ايش؟ We take the anterior previously, but now everybody is counting also the posterior. This is the new trend. لنفرض 91 180. ما تطرح. ما في شيء اسمه تطرح. ليه؟ manifest, you will include the lens and you will remove the lens. Okay, let's say you will not add the amount, the total amount, and the astigmatism. You are adding one cylinder on different axes. So, لا, you can use vector analysis. What is vector analysis? Vector analysis, you will have two astigmatism on different axes, and you want to add them together and get the sum of these values. So you have to go to online calculator from Albans. في واحد اسمه Alban سوى فورمولا اسمها أو طريقة اسمها vector analysis. So the total here for this patient will be minus 1.1 axis 005. طيب كيف؟ Barrett will estimate. طيب يعني هو عنده data set, data of patient, it will estimate. But you can go with anterior for Barrett, but it will estimate the posterior. طيب. So this is the axis of the flat K on the anterior surface of the cornea. طيب. And in the machine, you can change it to steep axis. For oblique corneal astigmatism, if it is less than 2, it's okay. But if it is more than 2, you should be suspicious. Any astigmatism more than 6, it's abnormal. We cannot diagnose the patient based on only one abnormal value, as this patient is keratoconus. No, we cannot. We have to see different abnormal values and then decide if this abnormal topography or no. Okay. If we have disparity between tomography and manifest astigmatism, you should, the causes include misalignment or corneal causes like corneal opacity or irregularity, because in the pentacam also it will not be that accurate. A hotspot syndrome like corneal irregularity, tear film disturbance or instability, post-contact lens wear, tear film disturbance. Lens causes for this discrepancy or disparity is could be the cylinder coming from the lens, or if there is IOL, it is IOL tilt. IOL tilt will induce astigmatism. Okay. So, and some will go for Orbiscan if they want to decide the axis of the anterior surface. Okay. So they will go for Orbiscan. It's more accurate based on studies. This is the mean radius of curvature of 7 to 9 millimeter ring area, and this is the minimum radius of curvature. هذه جينا. طيب. This is the back surface. هذه كلها جاوبها عبد الله. طيب. Now the bachymetry. Usually the pentacam, it will calculate the bachymetry of the cornea from limbus to limbus because it is tomography with an accuracy of plus minus 5 micrometer. Pupil center and bachy-apex. Bachy-apex means the center of the cornea. Okay, and the pupil center is the center of the pupil. why we should take the center of the pupil and the back apex, we will come to it. So the center of the pupil here, the location in X and Y. طيب أحد بس يقول لنا وين بيصير nasal ولا temporal؟ إيه depends on which eye. طيب فالإكس البلس وين؟ to the right. أي طيب لو فرضنا أن هذه العين اليمين أي بيصير نازل. أوكي طيب so the visual axis of location. Pentacam does not have Placido based system. As we mentioned before, it is just sham flag, one camera of sham flag. Okay, there's another camera for fixation in the center. The sham flag camera is only one and no Placido. Unlike Orbiscan, Galili, or others, tomography, the visual axis in the Pentacam, because there is no Placido, is between the pupil center and back apex, and usually it is smaller in myopic patient and in the dominant eye. So the angle Kaaba here, if we want to calculate it, it is the pupil center, the coordinates of the pupil center plus back apex divided by 2. If it is normal, if it is less than 0.1 millimeter, and suspicious if it is more than 0.1. طيب شلون؟ المفروض you add them together. طيب add them together. If you will go for trifocal, you add them together regardless of the plus or minus. And if it is more than 0.5, you cannot go for trifocal. X, A. But if you will go for trifocal, you should use both. طيب if you will go for trifocal, use both. Let's say this one, this patient, if you will go, it will be 0.09. Okay, but you have to divide by 2, so the angle Kaaba here is minimal. Okay. طيب the central corneal thickness. This is the central corneal thickness. You can use it in glaucoma, for glaucoma. And the thinnest location, you have to comment about 4 things about thinnest location. ترى هذه مختصرة يعني لكم. The value of the thinnest location, the value, compare both eyes, the difference between back apex and thinnest location. The 4th thing is the relationship between back apex and thinnest location, the vertical coordinate. Thinnest location, the value of thinnest location, if it is less than 470, this is abnormal. If it is above or more than 500, it's normal. Compare both eyes of this thinnest location. If the difference is more than 30, this is abnormal. The difference between back apex and thinnest location, normal if it is less than 10, more than 10, it's suspicious. The vertical coordinate, if normal if it is less than minus 0.5, if it is between minus 0.5 and 1, this is suspicious. Abnormal if it is more than minus 1. طيب. Now we finished from the thinnest location. 4 things to be يعني you have to comment on. And the Kmax is Kmax is the steepest K on the anterior sagittal map all over the cornea. Whereas K1 and K2, it's only the central 3 millimeter. Okay? طيب. The Kmax, you have to comment about 3 things. The value of Kmax, compare both eyes, and the difference between Kmax and K2, which is the steeper keratometric reading. So the value, if it is more than 50, this is abnormal. If it is less than 47.2, this is normal. Compare both eyes. If it is more than 2, it is suspicious. And compare also the Kmax and K2. If it is more than 1 diopter, this is suspicious. So thinnest location and Kmax. 4 and 3 things you have to comment on. طيب. This is white to white in the cornea, and this is the angle. If it is less than 22.4, this indicates shallow or occludable angle. with sensitivity and specificity of 81% and 91%. The chamber volume, it indicates also that the patient needs a YAG-PI if it is less than 84 with this sensitivity and specificity. The AC depth from the endothelium to, from the endothelium at corneal apex. It is important in phakic IOL. Here it is INT, means internal, so it is measuring from the endothelium. If it is EXT, this is from epithelium. In IOL calculation for IOL master, measuring from the epithelium. Okay. Orbis scan, Dr. Mohammed قلت لي. طيب. The pupil diameter, this is cotopic pupil diameter, and this is the IOB adjustment based on the central corneal thickness. Lens thickness can be measured if the patient is dilated. But usually we are doing the pentacam before or after dilation, or it doesn't matter. Why? Should we do the pentacam before or after dilation? Okay, كلها صح. أول شيء الفيكسيشن. Okay, الفيكسيشن، الأي depth. أشياء كثيرة بتتغير عليك حتى الأنجل. طيب، you should do it before dilation, not after dilation. Like the IOL calculation should be done before dilation. No IOL calculation or pentacam should be done after dilation to get accurate results. طيب, corneal power maps. We have anterior axial sagittal curvature, this and tangential, true net power, total corneal refractive power, and equivalent K reading power. Curvature map does not represent the optical power of the cornea, despite in the units in diopter. Why? Because we have to apply Snellen law. Otherwise, you cannot measure the optical power of the cornea. So in axial, we are not measuring the optical power of the cornea. Also in tangential. Axial versus tangential curvature map. Let's say this is the cornea and this is our reference. This is we will measure this dot or this area on the cornea. This is for the axial radius of curvature. We will use this. We'll use this radius of curvature for the axial curvature map. If we will use based on best fit sphere, if we will use tangential, we will have another radius of curvature, depends of central or peripheral. In tangential, each point will be calculated separately. On axial, no. We'll take one reference and we will calculate based on this reference. So in tangential, if it is on the periphery, you will have long or large radius of curvature. So the periphery will be flatter. Clear? Clear? A. So in the periphery will be flatter K. This is tangential. In the center, it will be, the K readings will be even more than the axial. I will show you one picture about it. So here, the sagittal, it is the default here. And this is the tangential. You can see here, the flattening is exaggerated and the steepening is exaggerated. Clear? Tangential, it is a better tool to identify keratoconus cone, but the best way is the posterior elevation, okay, using best fit sphere. Some studies suggest that tangential are more sensitive for early keratoconus and progression than axial map. It is less sensitive to eye misalignment, but the disadvantage is low measurement repeatability due to higher sensitivity to noise and tear film. And this table will compare two. So the axial and tangential. The tangential, we will have the apex K readings will be higher values than the axial. The cone of the location also will be, cone location will be more central in the tangential. Sensitivity to curvature changes higher in tangential, more noise. Okay, sensitivity to tear film irregularities more with tangential. Sensitivity to eye misalignment lower with tangential. So here's the axial and the tangential. You can see here it is 53 on axial, but it is 57 on tangential. True net power. Yes. Otherwise, you will cancel. If you want to use the K readings from Pentacam on IOL calculation, use the axial, not the tangential. True net power map, it calculated from sagittal curvature map, which is axial, from the anterior and posterior surface. The true net power values obviously cannot be inserted in IOL formula based on the refractive index of the cornea, which is 1.3375, because this would be amount of double correction. Because this value is corrected now using the true net power, and the IOL calculation will also correct the K, so you will have double correction. And this is the equation that we are using to get the true net power map. So in true net power, you will have lower K. And the IOL calculation, usually, if you put on the IOL calculation 44, the machine will count for, let's say, 43.5. Okay? Why? Because it will calculate the back surface also of the cornea. So if you will use the true net power, the 50 will become 48, and in the IOL calculation it will become 47, so the patient will be myopic. لا, don't use it هذه. No. Same case from the axial sagittal, but this one you cannot.
That is basically based on the assumption that the corneal refractive index is 1.3775. So it does the true net power, and then it uses the assumption, okay? And then
Sim
case, I think it's like the flex.
Sim K from here, you can get the Sim K. But because this is related to the axial sagittal, but the tangential, you cannot use it, or the true net power, you cannot use it. Because it's modified. You will have two modifications. Like the AKR. AKR, you cannot use AKR for on Ascaris website. You cannot use it. Because the Ascaris will also change it, and the... don't use it. Don't use it unless you will go for not the IOL master in the website. Website, there is a box for it.
You put it, but then they do the back calculation.
I know. The true net power. But you cannot use this true net power in the box of simulated K. فهمت علي؟ اي yes. والله هم اللي عقدوها. بس هم فهموا خلاص، هذا مو بلازم، والله مو بلازم. طيب refractive power map, the refractive power map used to interpret the quality of vision achieved after corneal surgery, okay, like refractive surgery, and it used the Snellen law, and it is relative to the fovea. Usually here, if you can see that in refractive power map, the readings here is lower than the peripheral. Okay? So if we use 7.7 millimeter radius of curvature at the center, the K reading will be 43, whereas at 5 millimeter it will be 50. This is just to know the quality. Is it homogeneous or non-homogeneous? Only. طيب. Interpretation. Now, the axial sagittal curvature. The eye, right eye, this is temporal and nasal. And you can see the 0 and 180. 0 هنا. طيب. لو في العين الثانية بيتغير النازل temporal, but 0 and 180 will be the same. And this is the corneal diameter included. We can include 12 millimeter for, let's say, we are examining the patient of pellucid. We can include 12, but the reference we are using 8. Okay. So here, same patient with different corneal diameter used. This is for the same patient. But we are usually we are using this one, up to 8. This is the color scale in this topography is vary from 2 diopter to 10 diopter. Each step can be adjusted up to 0.5 diopter. And this is for the same patient with different color scale. Same patient, same K readings. Usually we are using this color scale. هو أنا تقريبا 8 بس إنه يعني شوي من بس إنه يسمى 8 أنا عارف إنه مكتوب 9 أي عادي عادي. طيب this dots mean extrapolated data. طيب معناها الماشين not accurate at this area. Clear? طيب we should get to have a reliable test 8 millimeter without extrapolated data. Otherwise the best fit sphere will not be accurate. And because of this difficulty, we are using 8 millimeter best fit sphere. Otherwise, we will use 9 to include more cornea. But we are using 8 because we don't want the machine to use extrapolated data. Okay? So you have to check for this patient, it's okay because this is up to 12. But 8 is okay, no extrapolated data. Clear? This is the central dotted circle. This is the pupil size of this patient. And this is the keratometric readings. Usually it is steeper in the center and becoming more flat on the periphery by 2 to 4 diopter. Usually the nasal area is flatter than the temporal. And if there is difference between the central and the peripheral is more than 4 diopters, ectasia should be ruled out. Keratometric readings, when you are reading this map, you have to comment on 4 things. The value of K readings, asymmetry, superior, inferior, or inferior, superior, skewing, astigmatism, pattern. So the value, if it is more than 47.2, this is abnormal. Corneal irregularities, based on the axial sagittal map, axial sagittal, not tangential, okay, can be evaluated by disparity between inferior superior and by skewed radial axis value. So if there is skewing and disparity, okay, this is to evaluate the corneal irregularity. So the inferior superior asymmetry, or what's called asymmetrical bow tie, you should compare 5 points from the superior part of the cornea to the inferior part of the cornea, okay, at 3-5 millimeter. The skewing, usually the cornea will be become skewed superiorly, and if we have symmetrical bow tie, usually the fate of this symmetrical bow tie, the superior part will become skewed, and the inferior part will become more steep. Okay, so so here the asymmetry, if it is the inferior is higher than the superior. Normal if it is less than 1.2, abnormal if it is more than 1.5. Whereas if the superior is higher than the inferior, the abnormal value should be more than 2.5. Skewed radial axis, how to calculate the skewing, the angle. Okay, that this angle, this one or this one, it is the same, huh? So if it is more than 21 degree and the astigmatism is greater than 1 or 1.5 diopter, this is significant. If the astigmatism is 0.5 and the angle is 30, this is not significant. This is not skewing, not significant skewing. So the amount of astigmatism يعني you should check the amount of astigmatism when you are calculating the skewing. It quantify the irregular astigmatism and can be false positive in 0.05% of normal population, but it is not an early sign of ectasia. So here, this is the skewing. This is the angle. Clear? The astigmatism pattern, we have round, oval, superior steepening, inferior steepening, irregular, symmetrical bow tie with a skewing, or asymmetrical bow tie. So the amount of steepening and the axis orientation, this one, we will follow this two asymmetry just to know the pattern of this astigmatism. So the most suspicious pattern is the one on the 4 and 9, 10. It is asymmetrical bow tie with a skewing. If there is asymmetrical bow tie with a skewing, it is more dangerous than, let's say, asymmetrical bow tie only. So the abnormal pattern is butterfly and claw and junctional patterns. في الاختبار يجيبون زي كذا. Name this astigmatism pattern. كيف؟ كيف؟ توني جايب لكم الباترنز. وش الباترن هذا؟ inferior steepening. طيب inferior steepening 4 حاط عليه أحمر. طيب 3 causes of this astigmatism. أيوة. ectasia. طيب زيادة. scar أو decentered hyperopic ablation. طيب. if you want to know the pattern, you should divide the cornea into 2 halves and compare superior and inferior. طيب. This is central flattening. طيب. Mention 2 causes. Myopic ablation. scar. طيب. Bachymetry. The bachymetry, if you can see, this sign will be here also. So this is the pupil center. This one is the brachyapex, and this one the thinnest location. So this is the thinnest location is here. Clear? طيب. So the pupil center and thinnest location. The thinnest location here, you should comment on y coordinate, corresponding elevation. This is very important. If it is correspond to the elevation or no. يعني you cannot finish the pentacam station without saying is it correspond to the elevation or no. Asymmetry and the shape. So here, if you use more detailed map, this is one large map and this is the regular 4 refractive maps. Here, if you follow the thinnest point, it is 455, whereas here the true is 453. So that's why when you comment on the bachymetry, you should not say the thinnest area is 455. Okay? So here also, the thinnest you will say 574, but actually it is 573. I know it is small difference, but you have to know that the comment of the thinnest location from here. Okay. The thinnest location, the coordinates, the y coordinates, it should be less than minus 0.5. This is normal, abnormal, -1. Right. Corresponding area of elevation on the cone, on the other and the posterior elevation. Superior inferior difference, compare the central 5 millimeter circle. So if the difference between the superior and inferior less than 30 is normal, above 30 abnormal. طيب متى يصير عندنا less than 30 يعني في difference? Why there is difference? يعني let's say 25. طيب إذا المريض لابس عدسات. طيب فهذه تفرق لك if it is related to the contact lens or ectasia. The shape of the bathymetry. You should also comment on the shape. Is it dome shape or it is bell shape? Elevation map. The reference body shape, it could be a sphere or toric ellipsoid. So toric ellipsoid, it's masking the cone. The diameter, as we mentioned, it should be 8 millimeter. Here it is auto. Okay. Auto means it could be 9, it could be 6, it could be anything. Why? ليه الماشين تختار هنا اختارت 8.76 ليه ما اختارت 5؟ اكسلنت. من اللي يجاوب ما شاء الله؟ ف بس تعيد الجواب. فهمتوا؟ يعني الاكسترابوليتد area if it is 6 millimeter only, this is the most accurate, this is no extrapolation in 6 millimeter, it will take 6 millimeter. If it is 9, it will take 9. It will avoid the extrapolated data only. But you should check manual on 8, and yourself you should check the extrapolated data. Because if you are not requesting this one large map, you will not know what's the best fit sphere unless you concentrate more during the reading of the Pentacam. But you should not check the Pentacam for every patient. It should be manual, fixed to 8. خلصنا. طيب. Elevation map. On the elevation map, you have to comment about the cone location, the shape of the cone or elevated area, and the value of elevation. The cone location can be central within 3 millimeter from the center of the cornea, or peripheral if it is more than 5 millimeter. If it is between 3 and 5, this is paracentral cone. The shape of elevated area, it can be regular pattern or irregular pattern. Regular pattern like central island. Central island, if you have even 0.5 astigmatism, you can see central island. But the symmetric hourglass appearance, زي هذا hourglass appearance, if you see this appearance, it is normal, but the astigmatism should be more than 1. Otherwise, you will not get this appearance. So the regular, you have central island, طيب, and symmetrical hourglass. Irregular pattern like tongue-like extension, skewed hourglass, and non-specific irregular pattern. But you should not consider even the central island abnormal unless it reached a specific value to say this is abnormal. But you cannot say this is central island and the elevation is 9, this is abnormal. No. So the isolated island, it's the most dangerous. How to comment? You can say there is a significant positive or insignificant. Okay? Isolated, central, paracentral, peripheral, island. This is the way how to comment on this topography. بالvalue. طيب. Hourglass appearance, it's normal and it should be more than 1. And you can see the hourglass only on best sphere. You cannot see it on best fit toric ellipsoid. Okay. So if you want to know the type of astigmatism, is it with the rule or against the rule? Here, this one will be against the rule or with the rule. طيب. Usually ترى هذه نفس البيشنت يعني المعلومية. طيب. قلنا هذه below or above البست فيت سفير. below صح؟ فهنا هذه هنا ستيبنينج. فإذا ما أعطاك هذه بس من البوستيريور elevation you should know the type of astigmatism. فهمتوا علي الR4؟ أي. If you understand the best fit sphere, you will know what type of astigmatism is this one. طيب. So this is tongue-like extension. The value of elevation. وش الابنورمال values للبوستيريور والانتيريور elevation؟ ابغى واحد يجاوب. Abnormal, normal values of 8 ملم كلها. لا بس اتكلم كم الاليفيشن. What is your reference? لا what is your reference المعلومات هذه؟ basic science course. لا أبغى كتاب، أبغى مرجع. طيب هذا الجدول تسوى في 2010. طيب بيلن وأمبروسيو they made this table and you can see that the normal values and abnormal values ياخذونها من standard deviation. Okay, normal or abnormal. Standard deviation in between. Sometimes you will label this abnormal elevation, but it is normal because it is within the standard deviation. And they are taking 3 standard deviation, not 2 only, for these values. Okay, so there is no correct and wrong answer. So here, the elevation, they studied the elevation for the front based on the apex. They will take the apex and see the elevation at the apex of the cornea. And also they study at the thinnest location. And they study it on the 4 millimeter of the elevation map, the central 4 millimeter. And they found that the elevation values اللي قلتها طيب should be on the thinnest location. If it is not corresponding to the thinnest location, you cannot follow these values. لا اي correspond. يعني الباكيمتري map you can see the thinnest location. Is it correspond to the elevation or no? If it is correspond, you can follow the numbers. If it is not correspond, you should go to elevation front max 4 millimeter. فهمتيها؟ لا اشرح لها. أنا ما قدرت والله، شرحتها مرتين. ما هو اكتيزيا إنها significant value, abnormal value. So here, let's say here the elevation, the back thinnest, okay? The median is 4, okay? 4, but they will take here standard deviation of 4.1. They will multiply it by 3. Then they will see the results. And they found that is significant. Okay, but not in this study, in another study. They found that the thinnest location is the most significant. Clear? فالحين بعطيكم الأرقام، بس ترى مو هو بشرط أي رقم قرآن يعني. طيب. even the K readings, when I say 47.2, yes, ترى ما هو بس 47.2 خلاص abnormal. No, it's not. يعني ممكن يصير 48 ونورمال. طيب لأن you are following a standard deviation and 3 standard deviation, not only 1. That's why here the percentile 5, 95 and 97.5. Clear? And I sent an email to Belen. I told him give me the abnormal values for the posterior. أي. Even I said, okay, the thinnest location, if it is 18, it's abnormal. He said no. Because this is standard deviation. I cannot depend on one reading. If it is 17, normal. 18, abnormal. ما في شيء زي كذا بالضبط. But in the Pentacam, we are using the Pentacam, the curvature, the thickness, to estimate the strength of the cornea for the refractive. But actually, we are not measuring the biomechanics of the cornea. So we are just estimating. That's why they are estimating, still estimating. طيب. Elevation map, so for the posterior, normal, if it is minus 17, plus 17, it should be in plus values, and abnormal if it is more than 20. بس ما هو قرآن برضو نفس الشيء ما تقدر تقول